To begin this afternoon session. Thank you. I will also like to kindly remember you to please turn off your mobile phones, and we will be having a little change in the program, so we will start. It's my pleasure to introduce Professor Lalita Santos, who has held the post of Assistant Professor at the Faculty of Medicine of Coimbra since January 2000. Where she also coordinates advanced medical degrees in nutrition. She has been head of the Department of Internal Medicine since May 2009, and she is coordinator of the Autoimmune Systemic Diseases Outpatient Clinic of Internal Medicine. She is also an expert in digital ulcers. She was the first in Portugal to use capillaroscopy in Scleroderma. Oh, excuse me. So please, would you...
Yes. We are glad to have Professor Matucci with us. Professor Marco Matucci-Cerinic is a professor and director of the Division of Medicine and Rheumatology at Italy's University of Florence. Professor Matucci is acclaimed in the fight against Scleroderma as one of the leading forces behind USTAR and the World Scleroderma Foundation, as a world expert in ulcer treatment. Thank you, Mr. Matucci.
Thank you very much. And I would like to thank the whole organization, in particular Untitled Kennedy and all the board of FESCA, for giving me the opportunity to talk to you today about a very simple recommendation on how to manage digital ulcers, or let's say ulcers in general, because you don't have only digital, you have other kind of ulcers in systemic sclerosis. When you see this slide, you see this is taken from, in Florence we have one of the, probably the most ancient first hospital that has been created in the 11th century, was created by the father of Beatrice. Beatrice is the lady who inspired Dante. And he created the hospital. In this hospital you can find some della robbia myolicus. And this myolicus, this is one of them, just showing the treatment of patient. This is a ward. And in this ward you see that there is a doctor, and you can recognize the doctor by the hat. The doctor has always the hat in the ancient medicine until the 19th century, and you can see that one doctor is exactly treating an ulcer. So this is actually a very, very old problem, more than 1,000 years. And we have to say that digital ulcers are a huge burden for the Scleroderma community. You see here the numbers in different countries in Europe. And you see that the impact is always very significant. In some countries, is over 90% the impact. And you see also the frequency that can be estimated between 30 and 50% of the patient. Behind this is ischemia, so the reduction of the blood flow, no oxygen to the tissues, and these tissues are obviously suffering and leading to what you see here, that are the digital ulcer. This is just a definition. You can see the definition. So when the epidermis is broken and the dermis that is below the surface is damaged, we define this as an ulcer. An ulcer can even become more severe, going down to the muscle and to the bone. And these are the complications. This is coming from a study we have done in Europe. You see, in this case, we have gangrene. That is a significant problem that we may have in these patients. And also we have amputation. So we know that the burden that patient with systemic sclerosis has to suffer is significantly high. And also we have to say that in the world vision, we have lights and shadows. Lights are not many, the shadows are very many. And when I show you this is the study still coming from Europe. analyzing the capacity of intervention of different centers devoted to scleroderma throughout different countries in Europe, from east to west, from north to south. And what is coming up is, first of all, there is a significant number of hospitalization, this adding up to the complication we have for digital ulcer, but in particular, when you look at what is called here in the red arrow, debridement, this is really very, very low. So what does it mean? It means that the care of digital ulcer is very low. It's very low. So there are not really units that are taking care of digital ulcers throughout Europe. So you can count them probably in one hand. So what do we think when we see a digital ulcer? We think that this digital ulcer is an important sign because it's a sign of progression. You see here, this is a chart of Paul Klee. If he could just think which would be his fate in the future, he would think a digital ulcer as one of the most important signs to predict his future. And in fact, when we see these works, we understand the digital ulcer are a hallmark that is very important for us to understand which may be the evolution of the disease and how much we must be remarkable in choosing the right treatment for the very patient we have in front of us and make very important choices. And the question is, when do you treat? Always. So an ulcer cannot be left alone. It must be treated either locally or systemically. And this is done in a team. So you have to know that when you are going to a center, you must see a team. Is a doctor, is a nurse, but you are in particular very important because you are the center of the attention and you are part of this team. So the team is not one man, the doctor. It's not only the nurse. In reality, there is a triad, and this is the patient in the middle and the nurse and the doctor who are helping the patient to understand what he has to do and how he has to behave, because we have a strategy. So you must understand that you must be part of this strategy. And this strategy is, first of all, abolish pain if you have pain, but also to have a local and a systemic treatment at the same time. So you cannot only have pills to treat an ulcer. You must have also a local treatment. So altogether, it's a whole strategy to improve the quality and preserve, actually, I may say, preserve your quality of life. The complexity is enormous. It's a huge complexity. But this is not dealing with you. This is dealing with us. These are our problems. But you have to understand that the complexity is very high, and the time that we must employ in the care of ulcers is enormous. This means also the costs are enormous because we have an integrated approach. And the approach is, first of all, in teaching the patient. So the patient, the first time that enters a unit, he must be taught what is important, what is not important, what he should do, what he should not do, how he should behave, how he should cover himself and protect himself. So this is very important. So the role of our nurses is absolutely pivotal in this. And then we have obviously the pharmacological intervention, and we have also the wound care that the nurses usually conduct on patient, and we have also, unfortunately, sometimes the role of surgery in our patients. So you see here, the concept of prevention is not only a concept of drugs, of treatments, is a concept of culture, is a concept of behavior that every patient should be taught to have, because the skin protection, the skin hydration, the nutrition that you should follow is very important, and also you should quit smoking. Yesterday I had a long discussion with one patient. How do I feel about smoke? I said, how do I feel? I can feel only one way. No way. Okay? If you want to prevent, if you want to preserve yourself, smoke is killing, is a killer, okay? And this is not me saying this is the reality, okay? So I said, but how can you convince the patient to stop, you know? And this is entering into the relationship between the doctor and the patient. So how can I convince a patient to quit smoking? Not easy, okay? But if you speak with the patient, if you tell the patient what to do and how to behave, obviously you must understand what means stopping to use the cigarette as a relaxing event or an anti-stress event or anything you may see in this movement to take the cigarette, put the cigarette and open and light the cigarette. So this is some that becomes, you know, traditional use attitude in the custom of every patient. So it's not easy, really not easy. But please look at number 4, rehabilitation. So rehabilitation is a part of the prevention. That is very simple. So these patients, the moment we are dealing with them, we are cleaning their ulcers and they start again to move their hands, they must be rehabilitated, in particular in the hands. And this is one of the main important points, because rehabilitation means function, means increasing the blood flow to the tissues. We have a lot of local treatments, a lot, more than 1,800 different products. So the work, the job of the nurse is very difficult, because she has to choose the right tool in the right moment that is concerning directly the conditions, and you have seen the complexity before of the panorama of the things that the nurse has to think how to choose the right ointment or the right gauze or anything that she will put on this ulcer to make this ulcer heal as soon as possible. But there are some very important paradigms to be followed, like dogmas. And the dogma is never dry an ulcer. Always keep this ulcer humid and clean, because this will allow this ulcer to granulate and fast to recover and create the epithelium that will go toward the center and will cover this ulcer as soon as possible. So you have, also avoiding infection is very important, and also removing the dead tissue, like necrotic tissue, is absolutely of paramount importance. And we doctors can contribute to your health just thinking in 2 ways at the same time. Shall I prevent? Shall I treat? You can say Matucci is a treater, so he treats only. He's a healer. He's not a preventer. But this is not the correct approach. So every doctor has a percentage of prevention, a percentage of healing. You have an ulcer, you treat, but you think at the next ulcer. So you treat how you will prevent the next ulcer, to stop the ulcer growing and popping up from your fingers or your legs or your elbows. Okay, so the doctor has to think how to do, how to behave, and what to do to stop the disease to progress. I personally, probably I am a preventer, mentally, okay? Early diagnosis, early treatment. But here you see some tips and tricks that go from protection, that usually we teach the patient with gloves, creams, and nutrition, to the systemic treatment that we doctors have to choose. First, not only to treat the ulcer and make the ulcer heal, but there is something that is beyond everything, and this is the treatment of the disease. You cannot treat an ulcer if you don't treat the disease itself. So you have to treat the disease. You have to choose the right drug to induce remission, to block the disease evolution. On this basement, you will create the treatment also for the ulcer, to prevent and to heal. And obviously, the local care is very important. So what is needed? We suggest strongly an early aggressive treatment that is local, that is systemic. We want to spare and preserve your quality of life, and we want to improve the survival. Why survival? What do the ulcer has in connection with survival? It's very simple. First, the ulcer is telling you that something is going wrong, also in the other organs. So when you see an ulcer, you have immediately to go to other organs and check all the other organs. The lung, either the vasculature or the parenchyma, you have to go through the heart function, the kidney function. You have to check the patient again, and you have to treat the disease accordingly, or even change the treatment because you see an ulcer is coming up. So in the whole vision, you see here that there is one point that is the non-pharmacological intervention, that is the patient education. So we need your cooperation desperately because you are in the center of that team you have seen before. Then we have to prevent infection and complication, but because we have a correct balance between prevention and healing, we don't want to think about surgery, actually, because surgery is our failure. But we want to think about pain relief, correct local treatment that will help the ulcer to heal as soon as possible. Obviously, beyond this, there is the disease treatment. That is the most important thing, because we know that these digital ulcers are a huge burden for you. They are one of the worst thing and painful thing and debilitating thing that we have and we experience in our everyday practice, because it's also the cost of management is hugely high, and the impact on the health system is unbelievable. So we should have really an early intervention with a clear approach, methodological approach, that is either preventing and healing rapidly, and also we should not forget that we have to treat as soon as possible the disease, to stop the disease progression, and possibly to gain as much as possible on the disease itself, that we know sometimes is progressing very slowly, sometimes very rapidly, and we have to understand what is going on under our eyes in order to choose the best treatment and tailor this treatment on the patient himself. I have to thank my co-workers that are helping me always, every day. Without them, I could not achieve what has been achieved in Florence, from those who are taking care of the digital ulcer unit to those who are taking care of the systemic sclerosis unit. So I thank you for your attention, and I'm at your disposal for any kind of question. Thank you so much.
Thank you, Professor Matucci. Thank you very much. Thank you, Professor Matucci, for the very interesting things, as always. Now we are going to move to our next speaker.
Thank you. Any questions? We will try to leave them to the end of the session. So it's my pleasure to introduce again Professor Lalita Santos, who has held the post of Assistant Professor at the Faculty of Medicine of Coimbra since January 2000, where she also coordinates advanced medical degrees in nutrition. She has been head of the Department of Internal Medicine since May 2009, and she is coordinator of the Autoimmune Systemic Disease Outpatient Clinic of Internal Medicine. She is an expert in digital ulcers, and she was the first in Portugal to use capillaroscopy in Scleroderma. Please go ahead. Thank you.
Thank you for the presentation, and good afternoon, and also thank you for the invitation. Well, my talk is about how we care for ulcers in a Portuguese clinic. And I'm going to tell you about our aims in our clinic, also the characteristics and the complications we pay attention to in our ulcers, and our routine for assessment, prevention, and treatment. So, as it has already been said, also the aim of our team is to prevent, to predict the ulcers. And if some ulcer appears, we relieve pain, we cure without complications if possible, and we want to stop recurrence. It's very important, of course, the teamwork. That is the most important. For physicians, nurses, and the patients must have the same objectives and work together for those objectives. The management of digital ulcers in our clinic, we just follow a step-by-step diagnosis, and even before the ulcer appears, and also a therapeutic flow reasoning based on our experience, of course, but also on the up-to-date evidence. Our patients know that even a punctiform ulcer can be a big problem later. They are very painful, as you know, and they develop mainly on the fingertips and on the toes, although they can have other characteristics. Also, we must avoid complications, infections, osteomyelitis, gangrene, and amputation, of course. So we must very early start the treatment and, most of all, prevent and diagnose early. We know that ulcers are the manifestation of the underlying vasculopathy and fibrosis that characterize scleroderma, and they lie on the Raynaud's phenomena, the endothelial lesion, the lesion of the vessels, and also the vasospasm. There are, anyway, other mechanisms, although we don't know very well the triggers that start really the ulcer. But other mechanisms like microtrauma, sclerodactyly, dry skin, and others can also start an ulcer. There are also markers. We know that, and we must be very attentive to that males are more prone to the frequency of ulcers, also the disease duration, and in diffuse form of scleroderma. And also if the patient has already had an ulcer before. So to these patients we pay more attention, and they also must be aware of that. We have also biomarkers, although we don't know all of them yet, but some angiogenic molecules or autoantibodies can also make us to pay attention to these patients. Imaging is very important. Nail fold capillaroscopy is of most importance because, as I think you know, it is not an invasive exam and can predict early or detect at least some risk for the ulcers. Also, we have other vessel imaging, of course, that you can use. For our routine assessment, we just go very deep in the history of the patient, aiming mainly to find the risk factors. Some of them I already told you, and those risk factors may possibly favor the becoming of an ulcer. Dyslipidemia, dehydration, microtraumas, we must pay attention to that. We also evaluate the function of the hands, the quality of life, and also the skin score. And of course, we perform the capillaroscopy. Capillaroscopy, as I told you, is very important to see the pattern of the evolution of the vessels, and if it is a late pattern, we can just go and be very attentive to this patient and more frequently monitor their fingers. Also, we use SURI. It is an index just to see the skin ulcer risk, and we try to fit our patients in a risk chart, let us say, so that we know that those patients with a history and a SURI a bit high, we have also to more frequently monitor them, because in the orange and in the red zone, they can develop more rapidly an ulcer. And of course, we start treatment or optimize their treatment. Physical examination is of course very important. We do a physical examination, but also the examination of the fingertips and of the ulcer if there is an ulcer. We also, most of the times, do a sequential series of photographs so that we can also see how patients are evoluting. But of course, primary prevention is the most important, and patients and all the team must be aware of that. So, because we know that many of our patients will develop an ulcer. You know that patients must keep the skin moist and supple. They must avoid pruritus and stress because they are vasospastic. They must protect the fingertips, treat cuts, control their venous phenomena, and, of course, to have a good relationship with the team so that they know if they have any doubt that they can contact us the sooner they want. They also must always be cautious, as you know, about cold exposure. Gloves and the body must always be warm. Not to carry shopping bags, they are vasospastic. Not to smoke, neither active nor passive smoke. That is also very important, and sometimes our friends forget that. Also, we can have a physiotherapist to help in the hand function, and also phototherapy for some patients. Pharmacological treatments, we must also deal with them. Some of them for treatment, some of them more for prevention, and some both. So we have to optimize the treatment whenever we suspect something is not okay. And also parallel with disease-modifying drugs and skin management, of course. Managing pain, it is very important because it has a considerable impact on the well-being of the patient and also triggers vasoconstriction. So, with local anesthetics or systemic ones, depending on the severity. Also, prevention of further lesions is very important, of course, and it is of paramount importance to keep the good function of the hands and also to improve circulation and, well, treat and prevent complications. If there is a macrovascular suspicion of some vessel involvement, we can perform other exams, Doppler or angiography or even angio-MRI. For local treatment, as it was told before, we have to evaluate the stage of the healing, the stage of the ulcer, and then apply the proper dressing. It depends if it is an exudative ulcer or a dry one, so we have always to evaluate that. Also, we must avoid antiseptics because many of them are cytotoxic to cells and local antibiotics because of resistance. Ulcers must be cleaned and disinfected, of course, and debridement sometimes is needed, either mechanical or chemical. Sometimes platelet gels or vitamin E gels are applied. They seem to accelerate healing. Surgery is the last resource, is the one we don't want to have, but sometimes it's needed for debridement or for sympathectomy. We can have sympathectomy in cases where vasoconstriction is very bad. And also we can have chemical sympathectomy with local infiltrations. This all depends on the evaluation we make of the patient and of the ulcer. There are, of course, other treatments and ongoing research. You know that in Scleroderma, research is always being done. So we have botulinum toxin, we have filgrastim, we have even fat transplant or hyperbaric oxygen that is always intended to treat renals, but of course directly treats ulcers. I don't have any experience on any of these. So for our conclusion, I can say that a correct therapeutic approach can be based only on raising awareness and providing information to our patients. Prevention is the most important. Patients must know they can refer to the clinic as soon as signs or symptoms of critical digital ischemia become present, or in case of an ulcer. Lifestyle and hygienic routines are fundamental, and even if there has never been an ulcer before. Treatment, of course, should consider, and that is a team approach again, and individualized also, the severity of blood flow reduction, the vasculopathy, the possible thrombosis, for instance, and of course, sometimes we need, if necessary, and an infection is suspected, antibiotic therapy and local treatments depending on the individual and on the ulcer. That's all. Thank you.
Thank you. Thank you very much, Professor. And we are continuing with our next speaker. And then the questions in the end, please.
I have the pleasure to present Yannick Courcoux. She is a member of ASF in France. She managed to combine scleroderma, a job, and a family, which is quite a lot. And she is a new representative to FASCA. So please, Yannick, go ahead.
Good afternoon, everyone. I was very impressed with the patient this morning. They came with a slideshow. I don't have a slideshow. So thank you, FASCA, for allowing me to speak today. I'm going to try to be the witness of many patients today who are all suffering with ulcers. I'm 44 years old. I was diagnosed 4 years ago with scleroderma. The first 3 years, I didn't have ulcers. The ulcers only appeared maybe a year ago. I don't know if I should be worried, as I know that they are symptoms of the evolution of the disease, if I understood correctly what Professor Matucci just said. We asked me to talk about pain, and I've also talked with a few patients today going around. And I think that when we speak about ulcers, I think what's interesting is that when you speak with a patient, they will tell you it's a different kind of pain than what we experience in the disease. And I had some people telling me the ulcers are the worst in this disease. Even though they might not be as life-threatening, let's say, than the kidney, the heart, or the lungs problem, but nevertheless, for us patients, they are one of the worst things, definitely. From the pain point of view, first of all, in the ulcers, there are different kind of pains. There are the pains of banging your fingertips everywhere all the time, which give you this sudden pain that sometimes you really think you're going to faint. There is a pain that wakes you up at night, and you wonder also you have taken your painkiller, what else can you do? There are the pains of feeling sometimes that you feel almost like your nail is going to explode, like if there was so much pressure under that you're also wondering, what's going on, sometimes even in fingers that do not have yet ulcers. The other things in the ulcers as well that should be said, I think, is the impact on our daily life. And I think that's what makes it also so difficult, on the little disability that it brings you in your life. Very simple things. When you have bandage everywhere, you cannot wash your hands. You change your bandage maybe 3 or 4 times a day. If you go to the toilet, how are you going to wash your hands? It's not really easy to rinse, or you cannot prepare food. I mean, if you have to cut a salad, if you have to cut vegetables, if you have, same thing. It's very difficult to handle your knife and to handle your vegetables. You cannot hang your laundry. It's wet. Your bandage are going to get wet. So you try to use the fingers that are still available. But if you got the thumb, then you cannot hold things anymore correctly. You cannot type on a computer. You get all of the micro trauma. So you type on a computer with only 2 or 3 fingers, and you try to hold the other ones like this, and obviously It's not very easy. You cannot put your earrings in the morning. You cannot button your shirt. You cannot grab keys in your purse or in your pocket without being worried of actually getting the strong pain of hurting your fingers against a sharp instrument. The other things I'd like to bring up as my personal experience is that we've been talking also of how to treat ulcers, but I find that as a patient, we found ourselves very much a bit alone in front of treating ulcers. It's sometimes very challenging to get access to a specialist or specialized hospital who are actually able to treat this correctly. So usually your physician or your GP is the first person you go to, but they might not know exactly at which stage is your ulcer and what you should do exactly. So this is my personal experience, but I find myself very often, at least on a daily basis, I think we all find ourselves being the first carer of ourself, doing self-caring for our ulcers. So we have to do our bandage several times a day alone, which is not easy when your fingers are damaged or you have several fingers that are touched by ulcers. You also have to try different creams because you're not going to go see the specialist every time at the different stage of your ulcers. It's not always easy. So sometimes I try a cream and 10 minutes after it hurts. So, okay, wrong cream for the day. So I unband my finger and I try something else. And then I realize it looks like, okay, it's going to go for the day. And maybe 2 days later, it's going to be something different that you will have to try. Different type as well of bandage. And maybe this is a call for research. But in those days where we are able to send things in a space very far, we still do not have proper bandage for fingers. And that's, for me, is absolutely amazing. I mean, I'm sure there is something more intelligent we can think of than what we are being given. And we were talking in the treatment as well of trying to find the balance between humidity, infections, and so on. Just as a personal experience, on this finger last summer, I had a very strange thing. And I spoke to 3 different doctors, so all of them specialized in scleroderma, and I had 3 different recommendations on how to treat it. So Professor Matucci and all of the other doctors that are taking care of our digital ulcers, I don't know if there are really set up protocols now for ulcers, but our feeling from the patient side that we're still a bit experimenting the different treatments that are available. That's all I have to say today. Thank you.
Thank you, Yanni. The way you spoke today, you represent us all. Thank you very much.
So now we will have time for 1 or 2 questions because we are over time. So is any questions? Over there.
My question is not concerning especially the ulcer, but it is concerning about the skin. Do you think that when I use UV light for the hands, it's good for the skin? Like a lamp, for example.
So you're meaning ultraviolet A light for the treatment of the skin?
I have a lamp, and it is written on it UV.
Okay, so usually, the treatment with ultraviolet light is made by the dermatologists, and this is done in reference centers because it's rather complicated, because there is also a drug treatment that is supplemented to make the ultraviolet light more efficient on the skin. Unfortunately, I have no idea about the simple ultraviolet light, like when you go to have a tan, there is ultraviolet light you can use. So I have no idea really if this can help for the skin or either for the ulcers.
Okay, and what about the making a massage with the cream, but with not to make myself, but in a specialist with ultrasound, a special machine?
Okay, so the ultrasound special machine, it depends why you are using the ultrasound special machine, because the ultrasound are waves. So it depends which is the strength of the wave that you are using, just for you to understand. If we have calcinosis in the hands of a patient, you can use ultrasound wave just to break the calcinosis and clean this, okay? The orthopedic surgeons are using this for the shoulders when they have big calcifications. So it's a bombardment with heavy ultrasound just to clean the joints. Now in the tissues you can use this, the ultrasound. In your case, I don't know what they are achieving using the ultrasound and the cream, because it depends what is contained in the cream you are using and why you are using this cream, for which purpose. Vasodilation, just for massage to make the skin more soft, or because you have pain in your joints or your pain in one tendon. So it depends the purpose for which you are using the cream as well as the ultrasound.
Thank you.
Do we have some experience with the hydrocolloid bandage? Because I tried it and they have only in giant sizes and I couldn't use it.
Sorry, I didn't understand. Hydrocolloid.
Bandage.
Experience with those bandages, those dressings, is it the question?
Yeah,
the experience?
yeah.
Well, it all depends on as I told you, on the stage of the ulcer. We just use wound dressings depending on the stage. That is, if it is an exudative one or a dry ulcer, depending. We have several ways to control. And sometimes, as it was told, sometimes it's just experimenting the bandage and seeing what the results, because sometimes patients are different, but we have to try on and see.
Okay, thank you.
Thank you. The last question over there, and then we will end the session with the last question.
Okay, thanks. Is possible more explanation for the treatment of hyperbaric chamber?
Well, I have no experience. Although I know I have only experience on diabetics because I'm an internist. So not on scleroderma. I never did it to my patients. But I know some experience in other centers. And if well indicated, no infection, etc., it can be worthwhile trying, yes. No experience.
Sorry, in Spain, passing of Madrid, it's very positive.
Yeah.
No, it's only...
Good. That's
Thank
good.
you.
So now finally the last question. Please go ahead, Jana.
I actually have a question about the treatment. I mean, is there a point treating ulcers if you don't treat Raynaud syndrome? Or should you always treat Raynaud syndrome and have special treatment for ulcers? I mean,
well, I think the treatment and the prevention is the same, really. Although maybe for ulcers, the difference is the local treatment and the optimization of some treatment that we are doing already. Because anyway, what we want to do is to control the Raynaud's and then avoid the ulcer. And that is what we must do. Then optimize the treatment if something appears that is an ulcer. It's because it is not optimized. But yes, they correspond each other, isn't it? They go together. Although inflammation and, well, there are sometimes some markers that show some worsening of the disease, so it's not only the Raynaud's, maybe.
Okay. Thank you all the speakers for having brought to us so many information, and also want to thank you for assisting. So we'll now close this session and move on to the next one. Thank you.
I'm Patricia Carreira. I will present you Alan and then you present the patients. Okay?